So hello everybody. What is the holistic approach to keratoconus management? So as you know, there are many more ways to skin a cat, and there are many ways to treat a keratoconic corneas. We all know that custom ablation is just not custom ablation. It's not just topography guided. I mean, every time we say topography guided, but we have to define what, how we use the topographic data. So we have anterior corneal wavefront, we have ocular wavefront, we have total corneal wavefront, which is derived from the anterior and the posterior surface of the cornea. We can have transepithelial PTK, we can have trans-PRK versus regular PRK on a specific cornea. And then we need to decide whether we want to treat the lower order aberration, higher order, or a combination of higher order and lower order aberrations. And we all know why are we doing all this kind of acrobatics, because we all know that DULC or PKP has limited effect sometimes in keratoconus. We have 27%, as was shown with Troutman. 27% will end up with high irregular astigmatism, especially when you remove the sutures in keratoconus. So finding alternative methods to rehabilitate the cornea before right away jumping to DULC is essential. So, but the main motto there is the less the better. So the main issues with ablation, with the customized ablation, is one, overcorrection; two, biomechanical insult to the cornea; three, remodeling, cornea remodeling. Cornea is not a piece of plastic; and four, stromal haze. The more we ablate, the more we have stromal haze. That's why we need to really have this motto: the less the better. And in order to achieve this motto, we have to outsource our aberrations. Outsource preoperative higher order aberration and postoperative lower order aberration. For instance, corneal ring segments or corneal allogenic segments are great to debulk the original higher order aberrations, so that we end up with little, so that we can really fine tune them using customized laser. Spectacles. It's not, it's not a shame. We have to think about the spectacles in rehabilitating the patient. So outsourcing lower order aberration. Patients should know that this is as much as a therapeutic refractive surgery. It's not purely a cosmetic refractive surgery. We can also outsource to phakic lenses. So whatever lower order aberration we have, we can outsource on the phakic lenses. And finally, we want to leave enough stroma so that we can revisit these corneas later. Nobody tells us that eyes in keratoconus we cannot revisit if we did already the cross-linking. We do PRK after cross-linking, we do PRK with cross-linking, but we can always do PRK after a PRK plus cross-linking, provided we have enough stromal tissue. And then there are issues with repeatability. So why it's important to outsource, let's say, higher order aberration, for instance, in that cone. Of course, we can attempt to do topography guided, corneal wavefront guided, ocular wavefront guided, plus cross-linking. But imagine the amount of higher order aberration we have to deal with. And two, imagine the repeatability of this area. Both topography and ocular wavefront guided will not be that much. We know the repeatability of the of Kmax, more than 50 diopters, is about 3 diopters. So huge. Now, after allogenic segments here, for instance, look at the remaining cone. Now, this has really good repeatability, whatever you're doing, topography or ocular wavefront, plus the higher order aberrations are low, so we can tackle them with customized laser. And of course, it's nice to have the ability to monitor the improvement and know when it's time to perform your topography guided treatment. For instance, this is preoperatively stromal elevation. So with the MS-39, we take the epithelium off, and you can see the major decrease in the stromal elevation postoperatively. This is 3 days out. And interestingly, if you look at the epithelial map, it hasn't kicked in yet. We know that there is a huge epithelial remodeling which contribute to the effect of the corneal ring segments. But here, 3 days out, it's still not there. So it's only the stromal flattening from the arc length shortening that is responsible for the whopping improvement in topography, which you saw. The epithelium hasn't kicked in yet 3 days out. And of course, you can monitor the epithelial remodeling and decide when is the next timeline to treat. That's why we think about the modalities. What are the modalities to customize a laser ablation? We have the topography guided modality, which is either purely topography guided, or depending on the laser you're doing, corneal wavefront guided. So from the topography, we take the corneal wavefront and we treat, but we can also have ocular wavefront. And ocular wavefront before was something, you know, completely out of the question, because we were having a lot of problem with low dynamic range and low resolution in regular Hartmann-Shack topographers. But we will see that this is not the case anymore. The interesting thing about ocular wavefront guided, specifically in keratoconus, is that it accounts for the posterior curvature. And that's important. We're going to see it in a second. So, and the nice thing when I have something like an MS39, which is part of placid in OCT, and I have a pyramidal aberrometer like the Pyramis or the Osiris, is that you can combine the information from both to have a holistic approach on the higher order aberration, both anterior, posterior, total corneal, and even intraocular aberrations. So for instance, with a case like this one, I did the planning in my laser, and on the left-hand side is the corneal wavefront guided, but then using the Pyramis, I did, or the Osiris, I did the ocular wavefront guided. And I looked at the ablation pattern in both. And as you can see here, the volume in the corneal wavefront guided is more than the volume of ablated tissue in the ocular wavefront guided, while it's almost the same. They look the same, but the volume is more. Now, Bruce Allen has elegantly showed that, and in most, but not all keratoconic patients, you can save up to 44% of tissue if you go with ocular wavefront guided. Now, of course, you need to have enough pupil size to have enough optical zone, and that's not always available. So sometimes you will have to go with topography or corneal wavefront guided, but it's always good to look at both profile and decide which is the best for this specific patient. And again, that's because the posterior surface is sitting on a negative meniscus. So the anterior surface of the cornea is sitting on air stroma, while the posterior surface is sitting on stroma aqueous. And that's why the coma or the curvature of the posterior surface will actually negate the anterior surface. So the total coma will be much less than the anterior surface coma. And I will show you a case that will typically display that. So I had that patient with, this is the Hexa map, and you can see this is the anterior curvature, that's the posterior curvature. And if you decide to go ahead either corneal wavefront or ocular wavefront, just first look at the MS39, and you can see that the anterior higher order aberration, the anterior coma, is 0.86 at 100. Okay, so how about the posterior coma? It's 0.41 at 286. It's exactly diametrically opposite, right? So that's why it negates the total, the anterior. So the total is actually, again, 0.43, but the other direction, 92. Now imagine if I want to proceed with topography guided, whatever laser you're using, topography guided or corneal wavefront guided. So it's anterior corneal wavefront guided. If I proceed with that and it's successful, I'm going to treat the 0.86, perfect. But what happens is going to leave the posterior coma unmatched. And actually the result would be exactly what the result is right now, which is 0.43, but the other way around. So instead of being at 86, it will be at 286, so, or 270. So it's actually diametrically opposite. Now, if I look at the Pyramis or the pyramidal aberrometer of that exact patient, we can see that the total coma, so the total coma, ocular coma, is actually the same as the total corneal coma, 0.46 at 92, which means that this patient, being young and healthy and doesn't have anything in the lens, does not have much of intraocular coma. It's mainly the total corneal coma. So with the absence of the modality to treat total corneal coma, anterior plus posterior, and we know that's ending soon because MS39 will be finally linked, at least if you own a Schwind, it will be linked to the Schwind laser, which means you will be able, for the first time, I think, clinically ever, to treat the total corneal coma and shape tissue. But in the absence of that till the very moment, I hope that's going to end in a few months, and it's actually already released, I decided in this case to treat ocular wavefront guided, and this way it can account for the posterior surface as well. And it will treat exactly what I'm seeing on the MS39, total corneal coma. And that's what I did for that patient. And then If you look on the pre-op versus the post-op topography, yes, it is better, but you might argue and say, well, it's not perfectly fine because you still have some anterior coma, right? And we need that. Why is that? Why do we need anterior surface coma? Basically because if you look at it, we made that anterior surface by half, 0.39 or 103, but let's look at the posterior. Well, at the total coma, it's 0. Why? Because the posterior still hasn't changed. 0.44 at 263, and basically it's subtracting from the anterior, so the total is 0. Now, when that patient, if the topography was really nice, he wouldn't be happy because now the posterior coma is an unmatched, and the patient would have told you, well, I see the same, however, the shadows were up, now they're down. So that's actually what we avoided by doing the whole thing, and that's why I call it a holistic approach. We need to really think not just on the surface, but beyond the surface. But again, the requirement for ocular wavefront guided is one, to have enough pupil size to treat all the whole thing and to have a high optical zone. You need a really great aberrometer with very high dynamic range and high resolution, which I can't find but in the pyramids. But again, as I said, ocular wavefront guided is important, but hopefully soon we'll be able to do total corneal wavefront guided using the MS39 as the input. Now, again, the other dilemma is Trans-PRK, or should I do regular PRK, or should I do Transpdk? We all hear about different protocol, the Keratoconus protocol and all other protocols. Now, it all depends on the epithelial maps, and that's another thing that's important to look at, not just the topography before going ahead with a custom ablation. We see maps that are thinnest point centered in the middle, like this one, very nice, very easy to deal with. But we have decentered maps, like this one, where the cone is decentered. And if you look at the central epithelial thickness is 53, but the epithelium over the cone is 44. Now, this is the tangential on the left-hand side. This is the Gaussian in the middle. And you can see that the Gaussian really is smack to that epithelial thin point, which is right on the cone. So if I decide to treat with a Transpdk, okay, what I'm going to end up is treating in the middle 55 and just at the cone, which is 44, and that's going to end up shaving stromal tissue from the cone about 11 to 12 micron if I decide to just do Transpdk, right? So now let's see if I decide to do a wavefront guided PRK, whether ocular wavefront or topography, in that case ocular wavefront. This is the ablation map on my laser. The red is where the pulses are the most, and the blue are where the minimum. So as you can see, most of the pulses will be on the cone, right? With that exception of the crescent, which account for total treatment of coma. So now, if you look at how much tissue, the red stands for, it's about 13 micron. 13 micron of tissue mainly on the cone. So if you compare Transpdk on that patient, so if I decide to do Transpdk plus cross-linking versus PRK, topography guided PRK or ocular wavefront guided PRK here, they're going to remove almost the same amount of tissue. And hence, they're going to have almost the same effect on regularizing the cone. Now, if I decide to do Trans-PRK, so wavefront guided Trans-PRK, I'm going to combine both treatments. I'm going to do a quote-unquote PTK, Transpdk, to remove the epithelium, and then a wavefront guided PRK. So I'm going to have double penalty. I'm going to have 13 plus 12, 25 microns are going to land on the cone. And that's what sometimes we don't think about. We just do trans epithelium because it's easy and nice. But in that specific case, we're going to double treat the coma. The astigmatism will change axis. And I've seen, and I didn't have time for that talk, but I can show you where actually the coma is flipped. And you have actually a steepening a little bit up if your treatment is successful. So that's why in that case, I would either do a Transpdk with cross-linking, and I think it will give you the same result as wavefront guided PRK. In this specific case, I decided to treat Transpdk. So I did Transpdk plus cross-linking. You probably heard of something like the Keratoconus protocol, but it's modified because here I put 55 microns, just the center. So I got ablated 55 in the center, but on the cone, I got about 11 to 12 microns of stromal ablation. And what I got is actually this 2 months later with Transpdk with cross-linking. And if you wait, because the effect of the cross-linking keeps on, at 14 months, that's the topography. From starting here to there. So that's only with Transpdk. So you can see how the epithelium can help you and can help you perform a Transpdk, which is supposedly a refractive neutral procedure. You end up with a great effect as good as a customized procedure in specific cases. And again, that's what I call a holistic approach, because we have to look at everything and see what's the best for that patient and for that eye. Now, finally, I want to introduce the importance of optical zone, and I like to call it the Athens Paradox. Now, Athens protocol was a pioneer protocol because after that, we all opened our eye to treat these patients with combined cross-linking. But I think the technology we have now should and urges us to go beyond the Athens protocol and beyond that very small optical zone of 5.5, and I will show you why. So again, that's what I call the Athens Paradox, and I will show you what is the paradox. So it's optical zone decoupling. So let's go just and see that patient, and you see this very steep topography in the middle. That patient had corneal rings already done before in another clinic, and he wasn't very happy still. He improved, but not a lot, and he was seeking improvement. So if you look at the topography, pretty steep in the middle, and that's the ablation profile. And if you look at the ablation profile and you look at the preview, this is his refraction. Now, of course, I'm not gonna treat a 4.5 diopter of myopia, and what the Athens protocol would tell you, treat a little bit of the sphere, 75% of the sphere, 75% of the astigmatism, as long as possible to stay within 50 microns. But in that case, no, it's not a cosmetically refractive procedure, it's therapeutic. So what I do, I change the constraints of my refraction to see what would be the lowest refraction possible while having the lowest volume in treatment. So the laser basically gives me this refraction, which means if I want to treat with the lowest volume possible, that's the refraction of the patient. And it's interesting because the astigmatism is almost similar to my refractive, and let's not forget that our refractive astigmatism has coma in it, so definitely it should be less if it's regular astigmatism, and less in terms of myopia. And that definitely will break down the ablation and the volume pretty low. So if I decide to go with that, and I look at how much ablation I have, it's really low now. But look at my optical zone. Now, if I decide to change my optical zone, right, and actually make it much less, is this gonna decrease? No. It's interesting, it has decreased from 25 to 27. So by decreasing my optical zone in this specific instance, I have more ablation. How is that possible? Okay. So this is the trick, and if you look at what our lasers do when we do customized treatment, so basically this is a customized treatment, and that's the lower order aberration embedded in it. So if the laser is going to treat some coma and some spherical aberration, it will induce a refractive change. It would reduce, it will induce an astigmatic change with some spherical change. If I tell my laser, no, the refraction of the patient is 4.5 with 4 astigmatism, the laser is going to try the algorithm to correct this lower order aberration based on what I tell the patients to do. If I tell the algorithm, don't worry, just treat the higher order aberration and let's choose the lowest refraction possible, which is embedded in it, so that's going to be different. And instead of treating 4.5, I'm going to treat less. Look at the optical zone. If I just treat the lower order aberration that are embedded in it, it just goes in width but not in depth. The depth is the same. I started from here, I went there, it's just going that way. The sphere minus 1.72 and the astigmatism are all embedded in it. It's not going to go deeper. However, if I decide to be a bit more greedy and say, well, I want to treat the extra sphere, for instance, I want to go ahead and treat minus 2.61 and not minus 1.72. Now, if I enlarge my optical zone, it's going to get much deeper because now these are just added. It's not embedded into my higher order aberration treatment. It's added, and now it's going to go deeper, just like a lenticle. If I tell the laser go 8, it's going to go deeper all the way down in the middle. And that's depth-dependent optical zone enlargement. But before, there is decoupling, almost decoupling. And that's important because if I want to treat coma, I want the biggest optical zone possible for 2 reasons. I want to treat all the coma, and I don't want the epithelial remodeling, which will be highest with smaller optical zone. So here, that patient we end up treating with a very large optical zone, and I didn't really flatten the cone. I don't want to flatten the cone. This patient is going to have an ICL, a phakic lens. All what I want is regularizing the cone. And that's how you end up with a very nice central cone. That's a little bit steep, but centrally and nice, and the refraction from 2150 to 2030 And you can see that the astigmatism decreased. The myopia didn't decrease much because I elected not to treat it. I'm gonna outsource it to phakic lenses and not, or maybe spectacle if you want. And now look at the curve, the MTF curve, which is much better now. And finally, when to treat with combined and when with sequential, and that's a big question. And I think this kind of major cone, I would treat with combined, but this one I will treat with sequential, for instance. I would just do cross-linking and see how the patient is doing. Because the priority here is not lower order aberration, the priority is higher order aberration. Here, it can be combined if possible because the cornea is much more regular, so we can predict the lower order aberration better. And of course, we have to keep in mind the tissue ablation rate after cross-linking, which is about 12%. And finally, should we use mitomycin C when we combine our treatments? And we have shown that actually mitomycin C is much worse, makes the haze much worse. And the time after that article, which we published with Farah Tafazi and Emilio and Ray Chetty, I stopped using mitomycin C, and amazing results we got. Much less haze. The haze is just like regular cross-linking. And that's why I almost always do customized treatment whenever I perform a cross-linking. So this is, by the way, the haze for regular cross-linking, and that's the haze when you do combined cross-linking with mitomycin C. Huge worsening in haze. And that's based on a software, octanalysis.com, which is our software, and it's patented, but you could use it online. So as a conclusion, customized corneal ablation, it needs to be holistic. It needs to incorporate all data, and the data comes from great aberrometer and great OCT Placido machines. You need to look at anterior corneal wavefront, ocular wavefront, total corneal wavefront, because soon you'll be able to treat from the MS-39 using total corneal wavefront. We have to think that it can be trans-PRK, it can be PRK, or even a Transpdk for that specific patients. And finally, we need to minimize ablation, treat mainly the higher order aberration, but that should never be on the expense of the optical zone. Thank you.